Here. Gotcha. Dr. Phillips and Sir Ball both told me they would not be able to attend, so they will not be here. We do have a quorum. We're going to start out the meeting the way we are supposed to, which I didn't do last time, which is to, as soon as I find it, read the mission and vision statement. And I have it somewhere here. So to remind everybody, the vision of GETAC is to provide a unified, comprehensive, and effective EMS trauma system for a healthy, safety Texas. The mission is to promote, develop, and maintain a comprehensive EMS trauma system that will meet the needs of all patients and that will raise the standards for community health care by implementing innovative techniques and systems for the delivery of emergency care for the entire population. Just to remind us why we're here. First item of business on the agenda, Dr. Nemeth, can you come forward and tell us how things are going with the TCEP EMS Medical Director Seminar?
So the Texas College of Emergency Physicians Medical Director Seminar, usually a separate event, has this year combined with Texas EMS Conference and is happening at the same time. So there's a track now during the normal period of Texas EMS Conference that is specifically geared towards medical directors. It is Monday and Tuesday, so the November 12th and 13th of the conference, and it's a pretty good program we put together. The final schedule and a topic will be going out shortly and be published with all the others as to what the topics are. And anyone who signs up for the conference, medical director, EMS provider, anybody who comes is welcome to come to any of the sessions. They're all open for everyone, so, but they will be given by medical directors. So. All right. Any specific questions about it, or?
Anything you need? Anything you need from us or from GETAC?
A lot of you are signed up to speak. Other than that, no, we're good.
Yeah, I think we all got roped in. I mean, we all volunteered.
Yeah.
I was wondering if I should ask him what it was exactly.
Yeah, I was going to say, what are we, no, you're distributing the content soon, right?
Oh, yeah.
Right.
And if you don't mind, just make my PowerPoint a keynote, and I'd be good.
I'll make it easy for you.
That's right.
Do we know which day this committee will meet during?
No, we do not yet have the
Usually
meeting announcements.
Saturday or Sunday?
Yeah, the GETAC itself should meet on Monday. Is that, I'm looking for staff. Monday?
So we'll have to meet Saturday or Sunday.
Saturday or Sunday. Is there, if there is a preference, we can put one in. We can't make promises. Saturday?
Because there's another medical director thing going on Sunday.
There is. You going to that too? Is it?
Some of you would be presenting that. That will be the gathering of Eagles League is on Sunday.
Okay, so we would like to request a Saturday date for this committee. Don't care? Okay. I will put that down. All right, the next agenda item, and I think almost everybody has something electronic in front of them. We have developed the medical director's page as part of GETAC, and we're starting to populate it with information. So if you have or could look at that, and Jarvis doesn't have something electronic in front of him, which is really weird. Yeah, I know. So the next two are actually a couple of items to be added to that page. First of all, we have 3 physicians in Texas that were, if you remember, the members of this committee agreed to serve as mentors for other EMS medical directors. So by default, we're all on the page. 3 other physicians in Texas have asked to be added. Doctors Hinchy, Kovar, and Purse.
Do you need a motion?
Yeah, why not?
Motion to accept them as approved medical director mentor list participants.
All right. Second. Anyone opposed? Let's consider that done. The next thing is there was a Fema Handbook that I actually heard about through some of my fire services. A little embarrassing that I had to hear about it that way. But on the website now and in circulation is the Fema Handbook from March 2012. Question is if it is reasonable to put that on our website as well as we start to look for one-stop shopping. I've looked through it briefly. I don't know what others have looked through it. If anybody has a problem with putting it on there?
I haven't read the whole thing.
I haven't read it
Now,
all.
we've
It's
got-
kind of thick, as I
It is
recall.
thick, and now we have the next one that was just recently released, that I'm still in the process of reading by the National Association of Firefighters that have their medical director guidelines. So,
Okay.
Yeah, I think listing it as a resource is fantastic, not the resource.
Okay.
Yeah, so
Yeah.
putting that in this would be fine.
Okay.
In the next meeting, we'll put the other one on the agenda, so it can also be added to the resources.
Okay.
That'd be a good discussion at our meeting of medical directors meeting during the conference.
About resources, yeah.
Okay. So I'll take that as a motion to place this on the webpage. Anyone opposed? No? Okay.
Is this a procedural issue for disclosure to do this as a individual motion, or can we make a motion to give you as the chair the authority to do that? Or?
You can if you want to. I thought it would be good for everybody to look at, because sometimes things like these come out, publications come out or organizations come out that we're not familiar with. And in case somebody finds something or has a problem with it, I thought it'd be better to vent
Okay.
through. Is that all right?
Yep.
Okay. Speaking of any other resources somebody would like to have placed on that page?
I think in fairness, you need to link the IFF resource that just came out last month. When was anybody knows?
I haven't seen it.
I will forward it to you.
Thank you.
It's a great cure for insomnia.
Okay. So, if you forward that, we'll put it on the next meeting agenda. All right. Is Dr. Kidd here? I have not seen her.
She's out of town. I don't know if there's a surrogate.
Okay. Is there someone else that would like to give an update? See, she isn't, she cannot be replaced.
Amen.
That's a true statement.
Item number 9 is, at our last meeting, we forwarded to the council a position statement about personal protected health information that was approved at the meeting. So I'm just giving feedback to this committee that that has been completed and done. So we can actually take something off our agenda as completed.
Did we skip number 8?
Great.
Yeah, we did skip number 8. Thank you.
Sorry, Mitch.
Sorry, Mitch. It's not like I didn't talk to you like 10 minutes ago, so yeah. Come on, Dr. Morber, can you update us?
Yes.
So my math isn't that good
I
today.
started this, the last committee meeting. In any event, this committee is primarily looking at the influence of pandemic that it could have on our society. Can you hear me? Try it. It seems to be working. Anyway, what we're looking at is the effect of the pandemic that can have on our society, because as the Department of Homeland Security and Department of Health and Human Services have stated, this is probably the foremost event that can affect us. It probably is the primary event that may happen, and it will have the most devastating effects on our society. So we're starting to look at this kind of like the deer in the headlights type of thing. When I talk to everybody, that's kind of what happens. They get glazed over. We have a state of 26 million people, and I have to thank Utah for not copywriting their guidelines so we can adapt it for us. Most of the states that have looked at this have 5 or 6 million, like Minnesota, Wisconsin, some of the other states. We are a very diverse economic, social, ethnic state. We have whole ranges from one end of the state to the other. And what we're looking at it as healthcare coalitions and incorporating the regional advisory councils and the health service regions as these entities. What we are trying to do is not crisis standards, because standards tell you you shall do or you shall not do. What we want to do is create strategies that can filter down as tactical events that the local regions can adapt and modify to fulfill what we are requesting that they do, so that everything will not be done in the same fashion, but will be done in concordance with each other. We have looked at a number of things. We have adopted the initial triage criteria from Utah. We have looked at that, basically to the call centers, hospitals, centers, EMS dispatch, EMS, if anybody makes a call. Series of questions. Should you be seen in an ER? Should you be seen in a doctor's office? Should you be seen in a triage center? Are you better off just taking care of yourself at home? And these things really have to be initiated at time zero. We then went on to look at the effects of both the exclusion criteria, the inclusion criteria, and the minimal qualifications for survival. In the exclusion criteria, what we decided was that the DNR was so fluid that we actually rejected it as a sole criteria, since you can actually say, I don't want to have this anymore. So we said a DNR with one other exclusionary criteria as a qualification. We have adopted most of what the other exclusionary criteria, and that includes children, also a DNR with one other exclusion criteria. We are going to look at the children's effects because the pediatric index of mortality is not a good index to determine who gets a ventilator. It really is evolved around the surgical ICU, and it works in groups, but we need a more individual criteria, so we're looking at the clinical respiratory score as the mechanism to determine who gets a ventilator or not. As you know, there's some 78,000 to 80,000 hospital beds, which at any given time, there are 56,000 that are staffed. There's approximately, and we don't know for sure, ventilators, maybe 6,000 in the whole state that are able to be used, and that's on the basis of saying 3/4 of the ICU beds can handle a ventilator. So we are looking at that as far as how we're going to proportion those out. We are looking at ventilator registry, centers of excellence, in other words, in larger communities where they have major institutions, maybe those will be the ones that will handle all the ventilators, and the people with less critical conditions will go to other hospitals. Or in some of the far west areas, maybe where everybody will have the ability to use a ventilator because we don't have centers of excellence, or a combination of same. But we're going to kind of talk about this and see if we can't get this down so that ultimately each area will decide what is best for them. We're going to have to look at mass fatalities. Mass fatalities are different. It's different from fatalities from mass casualties. So we're looking at institutions where we figure 70% of the deaths will occur in a hospital. How do we handle these? We will also go on and consider the EMS standards, and in fact on the 21st of September, half the meeting will be just for EMS, and we're going to go through the criteria and what we think is necessary as far as what we do in the field. We also have another number of issues that we're going to talk about. Use of social media. Those that were here this morning for the disaster committee saw Lockmollen to give his presentation. This is going to be a huge thing for all of us. We have to know when to start with social media, how to progress it, what do we do for public communication, what do we do for risk communication, and we need to develop a timeline from time zero to the end of the event so that we know at what stages, what are we talking about, what stages do hospitals start to transfer patients into other areas in their hospital, how do they transition patients that don't need ventilator status out of their hospital. So these timelines all have to be worked out. How do we work with social media, public service announcements? How do we get the word out on YouTube, Twitter, Facebook? And then what do our elected officials? We have a whole session to discuss elected officials and community leaders. We're going to spend a whole day discussing that. We're going to also discuss force protection because, as you know, it's not just taking care of our own in the hospital. Somebody has to supply the power grid, somebody has to supply the water, somebody has to supply the sewage, somebody has to make sure that whatever durable equipment and other supplies we need get there. So how do we bring the private and public center, the center's services, critical infrastructure, key resources, how they bring them in, and how do we talk to them about force protection? And then there's a cost to do this because it costs money to protect your own. So we're going to be discussing that. Finally, what we're going to do is the community aspects of spiritual care, because the faith-based community is going to have a huge voice in what's going on, especially if there's a true pandemic. And then we have to discuss what do we do for informed consent for those people that don't qualify. How do we get them to understand that these are the parameters and these are the only parameters where you will have the benefit from ventilator support. And then we'd like to take this on a road show and see how to implement this throughout the state, starting with the regional advisory councils and the health service regions.
All right. Any questions for Dr. Mortimer? Anything you need from this committee? Okay.
Next meeting is the 21st.
Okay. All right. Thank you, sir. I'm going to jump off down the agenda to the last item, number 18. There's a joint air medical ground EMS work group. I just attended a short meeting they had. like to ask, I guess, are you the chair of that work group, or who? Yeah, you were the one that lost the thing. So if you can give us a quick report.
We've met a couple times. Justin Boyd from the EMS committee. We've met a couple times. We had one conference call that we all attended or tried to visit with, and then we had a meeting this morning at 11 o'clock, 11:30. We've presented some questions that we hope that makes its way to Maxie and the state for some interpretation and some guidance on where EMTALA actually sits in the mix, and hopefully with the ability to lessen the regulatory oversight on the ground providers is kind of what the objective or what we're kind of hoping to strive for. So once we get some direction with the questions that we hope to pose to the state, then we can go from there and kind of move forward.
Could you frame the issue again for the committee, because we have such short attention spans, most of us don't remember.
The topic was the relationship between air providers, mainly fixed wing, and ground providers when we're talking about transporting patients, either inter-facility or sometimes there's along the borders there exists scene flights. We kind of get lost in language and translation as far as the responsibility and the liability that exists when an air provider is in the back of a ground ambulance and they're transporting either from the facility of the airplane or from the airplane to the facility. And we're trying to, we've seen some examples where we have out-of-state providers that exist that fly in, and if we have ground ambulances that are transporting patients under the BLS premise, and you look at the run report and all of a sudden a controlled substance was given to the patient, how is that supposed to be documented if they're not Texas certified? So that was some of the questions and the concerns that came up. And then we talk about is it a patient contact for the ground provider, and how's the documentation need to flow is if the air provider is the one providing the care for the patient. So we're going to hope to, it'll be addressed with you guys. It'll be addressed in the EMS meeting, committee meeting, which is next, and then tomorrow Air Medical hopes to be able to take that with some questions to GETAC, and then get some, translate the questions over into Maxie and Jane, and get some something that's in writing and on paper that we can look at as opposed to something that's being said.
Okay. Any questions for Justin?
Just the only question, you said something about EMTALA a second ago. Where is the concern of EMTALA in this?
You want to address that?
I was just at their subcommittee. There's so much overlap in I think the biggest issue is when you have two crews in the back of an ambulance, and especially when one crew is from another state, in the case of some air ambulance services, who's responsible? So, and then that's for ground and for transports. And then one of the issues being when somebody comes from out of state, who's responsible for that patient?
I understand.
And
that.
EMTALA covers that as the sending physician. So
that
there's
was
the overlap.
I
Yeah,
got
that's
you.
where EMTALA
I
comes
got
in.
you. Yeah.
For transfers.
That's the context you're talking about.
Correct. That's for transfers, yes. And that's the problem. I think there's so many issues here, they almost need to be delineated. And I think one of the requests, and I don't know if Maxie wants to discuss this or not, is one of the requests everybody's looking to the state for guidance as to whether or not the rules apply. When do the rules apply in the back of the ambulance? Do they not apply if the ambulance is truly being just used as a taxi cab? And
that's one of the questions. If we're actually, I mean, I hate to use the word taxi, but if we're using a vehicle as a mode of transportation for the patient from a facility to an airplane.
Sure. I remember all that. I just didn't.
Right,
EMTALA, I was thinking in the hospital aspect, but you're talking about the medical direction aspect. Gotcha.
Yeah, yes.
The other thing that comes up sometimes is a nurse from the ER decides to go on a transfer. Who's responsible? Who's liable if she gets hurt? Say they're in a wreck. Who's going to cover her if there's a drug reaction?
Or him.
Et cetera, or him, them. Who's going to take care of the liabilities at that point if a nurse is blended into the equation?
Right.
That's not trained in EMS, just one of our
Not
staff
licensed or
nurses.
certified as an EMS provider.
Right.
And we hope that once the questions are formulated, it's disseminated through you guys or a representative, so you can at least add input or qualify the question more if it needs more qualification from the physician standpoint. So we hope to do this properly in accordance with steps.
I don't know if, Maxie, did you want to jump into the fray on this? Or are you trying to stay in the corner?
I'll wait till I get the question.
Questions?
Questions, yes, and I'm afraid there's multiple questions, and I think they,
Answer it, the doctor is always in charge of that patient. At some point in time, that patient belongs with a doctor.
Correct.
The patient is a doctor. That will get the answer to the many questions, but it'll always be the doctor.
right. And, yeah, and I agree.
Afraid of that.
Transferring physician is the one responsible for the level
Right.
of care provided on transfer.
Correct. We agree with that. I think the issue still is even for the scene calls, those kind of things.
Became that medical director's patient at that time.
Yeah. Which one?
The one that whoever picked him up first. Whichever one got there first.
The one from Mexico sending them
Yeah.
in? Good luck trying to find that guy.
Yeah. And I think that the moral of this is we have to get some very specific questions to the state. It's not fair to put them on the spot with maybes. So are there any questions from the physicians, from the medical directors that we want to make sure are included? Specific questions.
I only offer I think what's stating the obvious, which is the caution associated with this, because whatever will spill into helicopter service and ground transport interactions on a daily basis and all those sorts of issues. So it's,
I agree.
it'll be an interesting discussion. So.
Yes. Okay. Did the subcommittee need more from us? Anything, I guess, anything very specific from this committee?
I think we're wrote draft questions from Maxie, and we'll take them to your medical committee tomorrow.
Okay. All right. Any other, this is one of the clearly muddy areas, so.
Yeah.
As long as it's clear.
It's clearly muddy.
There's clearly no good.
Yes. Going back next to number 10, posted on the web, and I don't know if we can get somebody to drive. I don't know if that computer's hooked up to the computer over there is hooked up to the display or not. Posted on the web is the Texas Medical Board recommendations or proposed language for Rule 197. I don't know if everybody has it in front of them or not. Let me find it. If you go to page 4, starting on line 15, we'll see if we can get that up there. Proposed language for the rule that we all have to live by. This is a second draft from the Texas Medical Board after letters from the TMA, an email from myself, a letter from TCEP that Dr. Nemeth penned, I believe. And there's language here that I would like for us to review. This committee cannot make a recommendation to TMB as a committee, nor can GETAC send a recommendation to the TMB as a council. So that is not that's not the way we function. I think this item, though, is worthy of discussion and worthy of us sending individual letters or having our organization send input. So I'd like to open it up for some discussion, starting with, as Brett's driving us there, starting with number 15. This is an item that has, I think, not changed a lot from before and that I don't understand. I think the intent,
The back signing of orders, is that?
yes, it's the implement and ensure all EMS personnel follow protocols that prohibit the back signing of transfer orders.
That's not.
Yeah, none of us understand what that is. From some discussions I've had, my impression is what's happening is a medical director for some of these less than best EMS services is saying, well, you hadn't paid me. I'm not your medical director effective today until you pay me. They get paid a week later, and he says, okay, I'm your medical director again, and I'll sign the protocols, or I'll cover you for everything you did in the last week. I I think, my impression is that's the intent
Yeah,
of
that
this.
was one thing they talked about. The other thing was the back signing after the justification form, position, what do they call position justification?
Yeah, but that's not the medical director that does that.
No, I know, but that came up in that conversation. with the
Right.
board. Primarily back saying, okay, they were back signing the protocol dates based upon payment. That was the main focus you were on. So the wording here, I don't think is what they're saying transfer words, but I don't think that's what they were.
No, I think it's either an agreement to be medical director or protocols.
Right.
I mean, because at the time you say I'm not your medical director anymore, the protocol date ends. So then they're functioning without a medical director for whatever amount of time.
Regardless of when they sign the thing again.
Right, regardless of when they sign it again.
Yeah, because when you sign it, it has an end date, which I guess they could keep saying that that guy's still on until that end date.
Well, they could, except the medical director resigned.
She related it to a medical director who didn't get paid. And they said, as the first of the month, I'm no longer your medical director. But then the 14th of the month, they got paid, so they would say, okay, I'm backdating my medical direction to the first. That's what they were talking about, but this wording doesn't cover that.
Right. Does anybody have,
And this is saying back signing of transfer orders.
That's why
yeah,
What is-
I know, it doesn't make sense.
You
to-
don't do sign transfer
Right.
orders. That's the sending physician from the hospital, not the medical director.
Yeah. Have we framed the issue correctly? I'm looking at Kathy Perkins, so that's their intent on 15, is to,
The problem we're seeing, it's not happening once, it's happening multiple times, where they're withdrawing their medical direction, they're letting us know, they're using us as an enforcer, basically, is what's happening. And then, when the provider realizes we've been informed, then they pay them, and then they say, I'm your medical director, and I was your medical director all along. And what we are seeing is not just a week, we had some examples, months,
Months of what?
months of, I'm not your medical director, I am your medical director, I'm not your medical director. And so what TMB is trying to get solid language in order to be able to deal with that. So if the wording's not right, provide them with some recommendations on the wording.
is there a name to the agreement? Or is it just verbal, or is it just the contract the medical director has with the ambulance service? I mean, is there verbiage that we could use that would make this more clear?
I don't know, I think we don't prescribe a particular, we don't have a prescription to prescribe how you must have a contract with the medical director, so
But you do have a requirement that there be a contract, right?
that there be a
Medical director's agreement.
Or an agreement.
An agreement.
So that should be
Yeah, that's the verbiage.
backdating of medical director agreement,
maybe that's the word.
not back signing, but backdating. of
Backdating of
Medical director agreement.
medical director agreement.
Contract, medical director contract.
Kathy, I'm kind of interested in this. Is this something that is happening multiple times by multiple different people or multiple times by the same? Okay.
Just to give you some sense, we've been really working with the medical board in a way that I've wanted to do for years. And finding a number of issues from medical directors that have previous enforcement issues with the medical board, from finding these histories that we're seeing. The comment that was made to us after a day-long meeting with my staff was this could be as big as the film mill issue. So, we've been talking about this for a while, that we were concerned. Some of the things that the medical board has shared with us that they're doing is there are people using the name and medical license of a physician that is in a nursing home. They are,
Is he dead?
in fact, we wanted to put eyes on one recently because he's 85 years old. He's 85 years old, and he says he has 30, about 30 firms. But then when we met with him, he said he only had 4, but then he followed back to us that he has 24. These things make us concerned.
Oh,
Did that meeting occur in the nursing home?
Not that one, no.
Okay. So I guess for number 15, we support the concept and we need to help the medical board with some language.
Phrase.
Is that? And I'm hoping everybody, again, will send their own letter. I understand the concept, and I think we all agree with the concept.
Yeah, but isn't it fraudulent enough on the face of it?
That was the big discussion we had at the board. It seems like all the rules about fraud should cover all of this to begin with, but
Or is the issue just that the medical board doesn't have the ability to regulate medical directors, and then anything in here about it allows them to regulate medical directors and physicians? But they just have to have some way to do it.
oh no, I think they have.
Well,
Medical board, I think, has all the authority they need already. That's my
This
personal
puts
opinion.
just more meat to what they can do, I think. If you're one of the guys that says, well, it's vague, and now it's not vague, it's clear that you
Yeah.
can't.
You didn't tell me I couldn't go back and sign the
Yeah.
protocols, make it retroactive.
Yeah,
Okay.
so you can't really punish if you don't have it, any kind of.
Makes it easier to enforce with the clarifications.
Okay. Let's move on, number 16. By the way, as it's projecting, the yellow was the original draft language, the green was additional draft language after first comments. One of the big things that was done was, I think the original word was entities, and that was changed to EMS providers. Farther up in the Rule 197, it defines EMS provider, just like DSH does, as being an ambulance service, not to be confused with personnel. So number 16 is actually what we've been asking for a long time, which is that you be listed with the medical board as an EMS medical director. Number 17 is the requirements you have to be an EMS medical director. A, within 2 years, either before or after initial notification to the board, do the following. I don't know what that means for those of us that did some of these things much longer ago than 2 years. I don't know if that's a problem. I'll throw that out to the committee. And then you can see 1, 2, and 3. And I believe either there previously was an or in there, or there should have been an or between 1, 2, and 3. Otherwise, you have to have all of those.
Yeah, I think you have to have an or.
And Dr. Nemeth, you were the one that caught this before I did. Is that correct? With
Yeah, that's my understanding, is that we wanted ors between them, so.
Okay.
1, or 2, or 3.
Okay.
All,
And then one of these things is a DSHS-approved EMS medical director course. How does DSHS feel about that? It doesn't mandate that you have to do it. It just says that
And there's
you
no
can do it.
hours in that course.
Correct.
It could be a 60-hour course if if that was the requirement.
Of course, you wouldn't have to take it. You have,
No, you can always go back to your 12 hours of CME somewhere, but.
assuming yours are in there, you could do, that would be one option of meeting that requirement.
That's true.
To answer your question, Dr. Greenberg, about most rules do not go backwards. You're asking about those of you who have taken courses in the past. Most rules, unless they specify, generally move forward.
Okay.
Okay?
But you have 2 years to do it.
So you're saying everybody would have to do it within 2 years? Is that what you meant? Or do you mean we're grandfathered in because we're already EMS medical directors?
You need to ask the medical board that for sure.
Okay.
What if you're an instructor? Do you have different requirements if you're an instructor in that course?
Yeah, I don't,
He's an instructor.
maybe we can get DSHS to approve it for us. I don't know.
Teaching it, you get credit.
For the entire course?
Okay. All right.
As long as the medical board.
Any more discussion on that point?
This is the other comment on 17B
But you're not going to get.
is formal CME and emergency medical services. And the question then is, how do you define that? Because like, one of the hospitals, like I'm credentialed at, says you have to have a certain number of hours in trauma.
Right.
But nobody defines what trauma CME is. So that's kind of an ambiguity. I could call an airway course, an EMS course, if I want it. Someone's got to define it.
Yeah. I don't have a problem. I like vague.
Yeah.
I was gonna say, that's exactly how I define those trauma courses.
Yeah,
that they
exactly.
require.
So you would add the word EMS, a formal EMS CE?
Well, it's okay to be vague, but we should at least go in and understanding that for somebody who doesn't do a lot of EMS, or somebody who's really not practicing according to current standards, they may be able to get away with calling just about anything an EMS course.
So you're suggesting adding,
Approved?
Well, I think that, for example, ethics courses are probably a little bit more defined.
Sure.
This is an ethics course, and maybe there should be something like what defines an ethics course as being defining maybe the requirements of an EMS course.
so CME should say, in a sense, CME and emergency medical services, medical direction, or,
I like that, in medical direction, yeah.
well, EMS, medical direction, all one,
That makes sense, because that does define what we're looking
Right.
for.
or CMS in the medical direction of emergency medical services.
Gotcha.
In EMS medical direction?
So you couldn't go take a
Right.
CPR course and
The
call it
intent of this is to
Correct.
continue education on,
medical direction. Okay. All right. Then section C is you can't be a medical director for more than 20 services unless you get a waiver, and you can't do it if you've been a bad person.
Does that include or exclude first responders?
it's providers, so it's only.
Providers, it's providers as defined by DSHS. And again, it's defined up further in the rule. So that's ambulance service, not first responders. All right, any comments from the audience? Any comments from the public on this? As you can tell, it's a big deal to us. Huh, Dudley's coming.
Oh, no.
Surprise, surprise, surprise.
On the piece on the medical director's course, you may want to make sure that that matches the intent. In that meeting with the medical board, the intent was that this group would advise DSHS as to what courses y'all felt were appropriate. Y'all were talking at the time of some online courses y'all were exploring and things like that. The key was to get all the medical directors pushing towards the EMS fellowship. But to get there, or why we're getting there, is to make sure all the medical directors took a course. But for those folks, there's a lot of our rural and frontier services that are concerned about that, so that's where the online piece came in. So you guys were gonna, if I remember correctly from that TMB meeting, you guys wanted the ability to approve those courses or to have a say in what those courses approved for Texas were. So if that's not clear in the language, or and I believe Kathy's clear on that, but we just need to make sure, however that needs to be done, that's.
Yeah, my expectation is that this committee's going to end up approving or sending forward recommendations for what gets approved.
2 dishes.
2 dishes to be approved.
Okay.
That's my impression. Hope.
Dudley just brought it up, and I just reread it. The sub 1, A sub 1, basically says that they can take any continuing and medical education.
Yeah.
They just have to prove 12 hours of continuing, not even in EMS or even emergency medicine, technically.
Well, it says related to this chapter.
Well, related to, defined as in section
166.2.
Oh.
And if you look at 166.2, that's just about general
CME.
CME
Okay.
and how doctors do CME in Texas.
Yeah, I read that too.
So that's not.
I got you.
It has nothing to do with medical direction necessarily at all. So we may want to just remove sub 1
So
and then leave it as dishes approved courses or board certification as your 2 options, and not have another option. That may be the right answer.
Or add the words.
EMS medical.
Medical direction.
Yeah. Dr. Nemeth, do you think if we added in 1?
My only concern, and I know your discussion on the continuing part, and that's good, is that there's no board that determines what EMS medical direction continuing education is, and so it would still be up to TMB, whoever they randomly choose that day, to decide if this meets, doesn't meet. I think you're much clearer if you just get rid of it, either leave it as a DSHS approved course or board certification. as your two options. But and then that puts it back in your control of approving what it is.
Does Dishes want that?
One of the other options may be some wording that would include that it's consistent with the core content of EMS fellowship training or whatever the right verbiage is there, because I think having an online or CME type of component, I think, will be important for the transition period. So I think we'd be better off trying to clarify that versus remove it completely.
Do y'all have any comment? Dishes have any comments or requests or?
I think crossing a line a little bit about what is appropriate CME for a medical director, but let me just say, for a position, but let me just say that one of the biggest issues is that they haven't had the input, the people, the subject matter experts in EMS with the board, and that's now changing. And so you are going to be the people, those of you who are willing to work with the medical board are going to be the people that help decide some of these things. And
Okay.
you need to be part of that. So I hope you are. I know some of you have already agreed to be part of that. So that's how those definitions get made, just like what we're doing right here with EMS. It happens the same way with
Right.
medical.
Okay. Yeah, and as an aside, I'm a peer reviewer for EMS medical directors. I went through the TMB process to do that. I don't know if anybody else in here has done that yet. It's actually not that much work as far as getting signed up. There is a list on the TMB website about who else is there, and I can't remember the names. So, and that's where that would come in. So, as you provide feedback to the TMB, consider whether you want to, how you would like to amend this, and the TMB can decide what they want to do, unless there's
We have
agreement.
our medical director's page set up where we're providing lists of things.
Yep.
Could we not be generating a list of courses?
Yes, I think we
Would
could.
that serve as
And/or
the
topics.
DSHS blessing?
I would think so.
I think the wording in I just needs to add the same wording that's down in B. CME related to medical direction to emergency medical services. Because the intent, obviously, we spoke about a formal course that doesn't exist.
Right.
So, and I know the TMA, or is it, yeah, the TMA has their little comments, but we're trying to overcome the issue that physicians acting as medical directors don't have any knowledge of medical direction. So this is not a perfect fix, but I mean, we have to do something. So currently we have nothing.
Okay. Everybody good? Any further comments on the rule? The last part is unchanged from prior. If you scroll down, Brett, can you scroll down to the next page? This has not been changed since the first draft. And again, this puts the burden on DSHS. And it says you're supposed to do a good job. All right. Okay. So again, please, since this, I will take this as a report to GETAC. GETAC cannot send or cannot, will not, should not send anything to the TMB, but we can do that as individuals, and we can work through our organizations to do the same thing. I think I saw somebody from the TMA here as well. Our Iris sits on the.
I'll definitely take it back to them.
Okay. And is Helen back? I thought I saw Helen back there. Yep, she's back there. So we'll work with the TMA and TSEP as well. Okay. Any other issues on that?
When would this be adopted, proposed?
This is to go before, you would ask that. I don't have my email up. It was on an email. I think it is October.
October board meeting?
Yeah, is that correct?
I think so.
Yeah, I'm pretty sure. I have the dates. Actually, we asked them to delay until we could meet here. I was hoping we could send a letter, but I was told we can't, so. I think it is the October meeting.
Actually, TMA asked them to delay until September, So it's actually, I think, set for August. They're asking to push it back to September.
Okay. All right. But we have a little bit of time, but we need to get our letters into the TMB. All right. Next agenda item would actually be number 12. The next several agenda items came from discussion we had at our last meeting of general topics. Number 12 is to consider the impact of EMS subspecialization by ABMS on Texas. I can't remember who brought that up. I think we should consider it. Do we want to talk about it? Crickets?
It's not a requirement.
No.
Any law. Its impact is how your providers implement it.
Correct.
My consideration is that it's a good thing.
Yeah.
Sure.
No, I agree. I think we all think it's a good thing. I think most of us in the room will qualify to take the exam if we want to.
I think the issues we're all going to be dealing with is trying to fulfill or meet the requirements for the fellowships and how that's all going to work with clinical practice on top of our requirements of ACGME on top of everything else. It's going to be an interesting time.
Okay, so do we need any action, discussion, or do we need to bring this forward? Or, again, I can't remember. It was in my notes from the last meeting.
Ira, do you mind updating real quick just the timeline? What's the process? I know you sit on. Are you right?
So it's been approved. So the ACGME rules went out for comment. That comment period, I believe, is already closed now. So they have to finalize them. Then the requirements for the fellowships will be released. After that, the exam occurs, I believe, 2013 is what they're looking at. They haven't set the exact date, but usually it would fall in the October, sometime in that realm of 2013 will be the first test. And then it'll be every 2 years is what I believe they've set it up as, to take and become board certified. Fellowships then also will start probably being approved fellowships 2013 is what they're hoping. Although they don't have that date out because they don't have the final paperwork yet.
We don't have the rules yet.
And the timeline for the practice track starts upon the approval of the initial fellowship, correct?
That is my understanding, that the grandfathering clause, which is, I think it's 5 years that it has before it will expire, starts on the time they can first take applications. So that'd be, again, whenever they set that date, but it's probably 2013.
Okay. Do we want to bring this back as an agenda item, or can we consider it?
I think
Just-
it's too early right now. I
Okay.
think ultimately where states or agencies go with this is still yet to be seen. And like one of the prior speakers said, the diversity of Texas is really going to see how this goes. It'll be interesting. But I don't know right now if there's anything
I think the only potential for us to do, and just to be clear, I'm not saying we should do this. I'm saying the only thing where I think the state has a dog in this hunt is to say whether or not that's required. And if we don't require it, I'm not sure we have anything to say about it.
I think that ultimately will come from the medical board. If it does, the medical board will have to say something. If you're going to function under this board rule, then you'll have to, like we're talking about the requirements. I don't see dishes having the authority to say that.
I agree.
Bobby, one thing that will be interesting as this moves forward is looking at the number of people who report EMS as a specialty on their annual licensure registration, whatever it is you know with TMB. And I don't know if I'm sure it's public information, I don't know how easy it is to access.
It is public information.
Those numbers, but it'd be nice if it's not easily accessible, we could find out once a year.
Yeah, does that need to be included in the checkbox of the rule, that not only do you serve as an EMS medical director, but
Are you board certified?
fellowship board certified,
Yeah.
fellowship trained?
Yeah. It doesn't exist yet, is the only problem. Nobody would be able to check that box.
It's not even an option.
So we probably get it from ABM.
Well, on your application, it has your postgraduate training, your boardings. I mean, that's all on there, that's all open record too.
Yeah, it's open record.
And it's a pull down, so you have to, there has to
Is
be.
it added to there, that's what you're saying.
Right, so I don't think it's an option for you to.
It's not on the pull down.
Yeah, it's not.
And I'm pretty sure there's not a write-in.
Yeah. And I found the email about the Rule 197 going back one agenda item. It's a committee of the board, and this is about Texas Medical Board. A committee of the board will be reviewing proposed changes on August 30th. Proposed changes will likely be up for adoption at the board's meeting on November 30th and would go into effect no later than December 20th if adopted by the board. So August 30th is really,
Public comment is,
public comment should be from, I think that would be August 30th to however long
Till November?
I don't know how long their public comment period's open, but then August 30th is the deadline we need to get letters in by, or before that meeting. And then November 30th would be when it would be adopted, or could be potentially adopted. Okay. Next agenda item, number 13, consider creating a position statement on EMS transportation to freestanding emergency departments and urgent care centers. There's been a lot of talk about this throughout the state, throughout the country, and some people have asked what's the stance of DSHS, what's the stance of the medical directors. Yeah, we're all looking at each other.
Beyond just freestanding, I think you have to take into consideration standalones. I mean, specialty hospitals that have an emergency
Right.
department that's truly not a hospital. I know in the Metroplex, these freestanding facilities are going into city council meetings demanding that ambulances bring them patients, that they need to be treated equally. I mean, it's a huge problem that we need to, to get a grasp around. Because on a weekly basis in my city, I'm sending ambulances from 911 calls to emergency departments, and that doesn't sit well with me.
Yep. Okay.
To freestanding. They call 911.
Oh, as in,
Yeah, they call 911.
Yeah.
And it's always high priority. It's
So
never just.
practically speaking with this, I don't know the real true reach that we would be able to have by a position statement than this, other than perhaps saying that one consideration might be something along the lines that it be a regional or a RAC. We support RACs developing what works best in their areas as a consideration or possibility. I just don't know how, it'd be very difficult to encompass a catch-all position statement that wasn't really watered down for these facilities.
Yeah. And let me.
In the history of this committee putting forth positions, we've always pushed it back to the individual medical director. I caution about a regional, point, because what if the region doesn't agree with what I wish and it's my medical license? So I think we should put a position or come up with a paper that recommends that each medical director have a policy or protocol to deal specifically with non-traditional emergency departments.
That's reasonable.
Don't we already have that?
well, I mean, one of the responsibilities is that you have
Destination,
you're responsible for destination determination.
Right.
That's right. But I think in the larger picture, most of the services, when they're transporting patients, they don't think of a freestanding ER as a destination. So a position paper that would include some sort of language about the medical director having a policy identifying potential other appropriate destinations, that's a consideration. But it gets very complex because not all of these freestanding places can do everything, and then they call 911, as you pointed out. So that's going to be a very difficult position paper to write.
Is this a need for DSHS before we go too far down the path? 3 rows of people staring back at me.
We're getting the questions, and this is an interesting conundrum that we have here. The people that originally wanted this license type wanted it. They were full service emergency departments, and they wanted to
Maybe we should adopt a policy that we don't take anybody to one of these centers unless they are licensed by the department.
That would be a good position.
Well, in order to be a freestanding, they have to be licensed.
Right.
Yeah.
So that,
And the
one-
stand, I'm sorry, go ahead.
I was just going to offer a suggestion. One of the things may be that there's a lot of controversy. There's a lot of misinformation. One of the things, I don't know if it would be beneficial if we invited entities or people knowledgeable, either through the racks or what other instances, to come provide some presentations on the subject, and then have a clear understanding. It makes it where we can't solve the issue quickly, but may give us a greater understanding of the scope of the issue and how to address some of the concerns with it may be an option.
Okay. So there's service directors out there. Is this a need for the services? I'm asking a question I know the answer to. Okay.
Probably more of a question for Kathy.
You can't tell by looking.
They could, or some have chosen to license with us. Some have said because we are under this hospital's license, then we're not going to license with the state because we don't have to.
Okay, so somebody want to take a crack at starting this document? Why is it so quiet in here all of a sudden?
Well, I think part of the issue is we're not really sure what it is that, as a committee, we want to do about it, or even the scope that we want to address it. I'm looking at it as I'm not sure we really have. I think that this is a very system-dependent issue. For example, I have no idea whether it's appropriate for MedStar to transport somebody to X facility, just like he doesn't know whether it's appropriate to transport to my facilities. And it may be in one and not in the other. So I'm not sure how, as an organization, we can really say something about it. So I think part of the issue is we haven't really defined what the issue as a committee is.
Well, we can give guidance to the state and medical directors on how to make that determination.
Maybe some of them don't know that the department has a licensing process.
Yeah.
And that if they go anywhere else other than through that process, you don't know what you're getting.
I think that it's a new enough concern and entity that the continued discussion by this group, even if we don't come with a final answer, the continued discussion will probably be enlightening for a number of organizations, entities, and medical directors as well.
What's that?
I'm happy to help take a crack at it.
Whoa, excellent. Dr. Bradley's going to take a crack
Houston,
at
you've got this problem solved, right?
Thank you, Dr. Bradley. I'll put that on the next agenda, that you'll have a very completed, grammatically correct position statement for us.
Would it be helpful to know the names and locations of those that are approved by the state versus the others that aren't?
I don't think so.
That's just the names, but basically, I like the idea of some sort of a reference document for a medical director making a decision. This is what you look for in making decisions.
See whether it's appropriate.
The state rules are you cannot advertise as an emergency room unless you are licensed either as a standalone under a larger hospital or a freestanding through the state.
Yeah,
And Jay, the Joint Commission is now crediting these folks. I mean, this is not clearly muddy. This is muddy. And it's dirty muddy. So.
You say muddy or money?
Yes.
Yes.
So, Dr. Greenberg, maybe, I know as I'm sitting here trying to figure out what to do with the freestanding EDs in my district, I think maybe one of the things that would be useful for the committee isn't so much a position statement, but a descriptive paper that's sort of outlining where we are, what the different facilities are. That would be hugely useful to me. Dr. Manifold was saying just continued discussion about it. I'm dying to hear more about it because I'm trying to figure out what to do.
12-hour, 24-hour, what kind of facility it is.
Absolutely.
Right.
And there are rules, and I think that's a good point, Jeff, because there are, the ones that are licensed by the state actually are required to be open 24 hours, are required to do medical screening exams, although they don't take Medicare or Medicaid. You know, I mean, there's a lot of things, and especially when you get to specialty hospitals that have an emergency department. So I think an informational paper would help me, because I spent hours online trying to find all this stuff, and it doesn't exist. You have to make phone calls and ask questions to people that can't answer the questions. So,
Good thing that's not so true.
yeah.
I think one question would be, are these facilities covered by EMTALA? But I'm not sure that that's a straightforward answer. I think some of them, depending on your license, may be.
Well, depending on the license, if they're
may not.
licensed as a hospital, then yes. If they're licensed as a freestanding facility, they are not required to abide by EMTALA, but they have EMTALA-like language in the statute.
Right.
Whether that's been
That makes it-
enforced
there's
or
another layer.
finalized by case law is a completely different story.
Something about the term EMTALA-like
Yeah,
just
yeah.
makes it right.
But I think one of the other issues when we talk about the independence is of our medical direction, as I think all of us would advocate for that. One of the concerns that I've had and we're addressing in our region, and I've committed to a regional approach to that, is because I think there's the potential, if I, as a medical director for agency A, said, no, I'm not taking anybody to these facilities, and agency B says yes, that's a fair conflict and would open up a significant amount of discussion and heat as well. So lots of variations on the theme, lots of issues that I think would be great for us to continue study and discussion on as a committee.
All right. So Dr. Bradley, it sounds like you got a really easy thing there. Dr. Beeson's already done the research for you, so.
Some of the
All
phone
right.
calls.
All right, anybody else want to just comment on this? I like to do public comments as we go, so. Moving on, number 14 also came out of the last meeting. Consider a position statement regarding medical director's responsibilities for EMS students on clinical rotations. And I don't remember who brought that one up either.
That was mine.
Okay.
And so, just for background, questions come up. I'm a medical director for an EMS training program, and they farm their paramedic students out around to the counties with the situation arising that any given paramedic student will show up with a particular preceptor at any given EMS provider, do a couple shifts there, and then go do a couple shifts with a different EMS provider. The question is, if that EMS student, if that paramedic student has a quality of care issue, is that the responsibility of the EMS provider's medical director, or is that the responsibility of the EMS training program's medical director? And I think that that is sufficiently murky that we don't really know the answer to that.
Okay.
Yes.
Yes, yes, what, yes,
But-
yes.
Yeah, yes, it is very unclear, because on the other end, being the medical director of the preceptor site, you know, and the student does something, obviously the paramedic they're precepting with is under my license. Where does that student fall under, and those students' actions, where does that medical direction fall under?
Well, I believe now, if you asked me to quote a page, I would be in trouble, but I believe the medical director of the training institution is responsible for that student, and that student carries a medical liability, as well as the medical director for the training institution carries that liability. So while as the medical director for the service, we'd have to deal with that issue from another respect, the actual medical liability is more likely on the medical director of the training institution and the training institution itself.
And well, I think you're probably right. Speaking as the medical director of the training institution, that hat, he's following somebody else's protocols. He's not following my protocols.
Because you don't have any.
I don't have any protocols.
Right,
On the
that's
other
the
hand,
education.
He hasn't been, I forget what the word is, but authorized by that medical director to operate under his protocols or her protocols either.
Well,
So-
that is a difficult portion of that question.
It's really no different than if a student rides on one of your trucks from a different training institution. He's in your ambulance doing an IV and it gets botched, whatever. Who's responsible?
I think, especially when you're talking about liability, obviously we don't get to decide who's liable or who's not. That's a court decision. But when I have a student functioning on my truck, I know that I'm going to be held accountable. So I look at it as that is my responsibility. So it's my responsibility, and I think I have the authority to enforce their behavior while they're working with my system. Now, I'm not responsible for their achieving their educational objectives and whether, so if that school wants to farm them out to a bunch of different places, I, as an educator, think that's a really bad idea. But that's not my responsibility as the system medical director. As the system medical director, it is my responsibility, and I feel like I do have the authority to say, you cannot, you have demonstrated that you don't have these skills. You don't get to ride with us anymore. I can make them go away. I can make them get remediation, or I can do something in between. And I think I already have that authority. And I certainly think I have the responsibility to do that.
Well, that sounds like a really good position statement you could write there.
Check your email.
I'm not online, sorry.
And actually,
I just sent you one.
I agree with that, but I think what it comes down to is not so much who is the medical director for the student, it's who is the doctor taking care of the patient. And that's the services medical director, not the school's medical director.
Clearly.
Yes. Yeah, I think no matter where, in whatever agreements are in place and liability coverage and things like that, as the transport agency service provider, that liability for that patient care is going to rest with us. It doesn't matter what protective or attempts at protective agreements are going to be put in place. That puts us as the medical director not only responsible, but then therefore liable for that care that's provided. I think so.
So do the folks on this group here think that, do any of y'all feel like you don't have that authority over students? Is that something that a position, do we need a position paper that just reinforces that and says that we think that not only you have the authority, but that should be in the affiliation agreement?
I could see how a provider could challenge the medical director's authority to say that we can't precept students from that school, especially as schools move or preceptor sites move to charging to be preceptor sites as a revenue source. I can see where that could be challenged because all the agreements that are required from the state and training programs are between the provider and the school. Has nothing to do, and there's no mention of medical direction in those agreements on either end. The medical director.
But the skills used on your service are under your protocols.
I agree with you.
And one of the things we started requiring is that any student who shows up to ride on one of our trucks has to show a skills proficiency checkoff list that has been signed by their instructor. And it has to be up to date, and it has to show I can start IVs, I can't intubate, but I can do this, this, and this. And on this date, I was approved to do these 3 things. Until I get the other 5 things, I won't do those. So that has been kind of soft in terms of the way we handled it in the past. Now we do require their instructor to sign off on that student as having been instructed and
before you allow them to
before they ever
ride
get on
service.
the truck.
So to wrap it up a little bit, is it the will of the committee that we do come up with a position statement? And Dr. Jarvis has actually already raised his hand and
Yes,
has done
sure.
about 80% of it already.
It needs to be written because right now it's not black and white. Who takes that responsibility? And if I'm the medical director of the service and I don't feel comfortable precepting students from the school, I don't know that I have the authority to say no to that provider because that's nowhere in rule.
And that's what I wanted to ask. What I'm hearing from you is that one of the purposes of this position statement is to give you the ability to go to your provider and say, no, it is my responsibility.
Yes.
Okay. Would this help the state?
It's your responsibility no matter what.
Would this help DSHS, or are we going to come up with a position statement that does nothing for you?
Well, we can always address it in blue last year.
Okay.
These rules, so if you need some harder language in there specifically say that if you have a position statement, then that gives us some ammunition for doing it.
Okay, so for the next meeting, we will have a draft position statement by Dr. Jarvis to be considered for adoption to send forward to GETAC. And Dr. Jarvis emailed me a draft, which really looks pretty good.
The word very, it was a very draft.
Very draft? A muddy draft?
Okay.
Next, moving on to number 15, we had a lot of discussion last time about impact of drug shortages on EMS. There was a recommendation we consider a position statement on drug shortages.
One frustration I have is that even though I have a statement saying that the drugs may be different than the ones on the truck, we still have inspections that show that we're deficient because we don't have this drug, which we haven't been able to get for months. You know, I can't write the protocol over every week based on which drug is deficient that week. It's
Right.
just too onerous. So we've got to have some cooperation so that we don't get dinged for, or at least perceived to be dinged for missing a drug that we can't get.
Yeah.
Otherwise, you're gonna end up with protocols that are gonna be multiple choice.
Oh, it'll just be
This
two.
massive if-then
Yeah, here's 180 different pain medicines, good luck. Shoot, well, we don't have this, let's try, okay, all right, let's use IV Tylenol.
That is, I bet you can get that.
I know it's actually $70 a shot.
It's expensive, yeah, you can get it. If it's expensive, you can get it. If it's cheap, it's on back order.
That's right.
That's the way it works. So, I don't,
So we just need to have.
do we need a
little
position
understanding.
statement, or?
I don't know if we need a
I
position
don't know what the
statement.
position's gonna do.
I don't
The
either.
law for
I didn't
the
get number
state
yet.
who's inspecting this truck is black and white. The state has put out a position that they will take that into consideration if a finding occurs, but they're still gonna have the finding.
Maybe we just need a way to change our drug list weekly. Just mark out, and then right on top.
You know, I was almost joking about the if-then statement,
Yeah.
but I just rewrote my RSI protocol, and it says, if this drug is not available, then
Yeah.
use this.
If not versed, then
Correct.
Yeah, I'm not so worried about the protocols. I think we do have some flexibility in our language in the protocols, but the equipment list is pretty black and white, and that's what the inspection is based upon, so.
yeah, it's just.
you know,
So the if-then perhaps
yeah.
needs to be in the equipment
Yeah.
list.
Yeah, so, and I don't know from Dish's perspective if there's, I know you've given us some opportunities with letters from the medical director to identify if medications aren't available, if there's some additional flexibility that we could explore there or not, things, so. As an update on a few issues that are out there in the area, one for medication shortage issues, it's not going away. It's not going to go away anytime soon. I think we all recognize that. We're all exploring different ways to manage it. Dr. Hinchy, I believe, is out in the audience. He and I are participating in a discussion with the Government Accounting Office next week as they explore it at a request from senators from Iowa and somewhere else to ask the GAO to investigate and ask some specific questions regarding the medication shortage issues. And the only problem with that is I think they gave them like a year time frame to explore that. So won't have an immediate impact, but still the professional organizations are trying to address and be politically active as well to help with this. And so be continue issues, and we'll try and keep the committee appraised of what those are. I think from the local and state level, I think we have to look at some opportunities to be able to identify maybe not position statements, but perhaps again suggested mechanisms to work through the shortage issues, and I think we have some folks who will try and do that for you.
Okay. So the will of the committee is no position statement on drug shortages.
Well, we can have one that says
It
they're
sucks.
bad.
Yeah. Okay.
Yeah.
I mean, the state's already put something out, and,
Okay.
and I don't know that we can.
I'm good with that. I don't remember where this one came from. It just came from a discussion.
Okay.
All right. Item number 16, update on CCMP option 5 from the state. Hey, we've already defined a patient. I had to find something.
Maybe we can talk about
It's
fire
still in rule. It's still in rule,
Okay.
but no organization has stepped up to say that they want to administer it. TTAF looked at it, if I'm not mistaken, but found out it's going to be more costly than beneficial. So
Okay.
that's the only group that I know that's actually looked at.
Okay. Is there a move to remove it from the rule?
Would you like to make that motion?
No.
Oh, then it'll stay.
We worked awful hard to get it there.
Well, we can always put it back if somebody step up. You can always put it back. But one of the problems we do have sometimes with DSHS Advisory Council, they have questions about why do we have so many options for recertification. That
I
has
agree
come
with
up.
that.
So
I agree with that.
just know that.
What was your answer? I'm kind of curious.
Because y'all asked for it.
We're warm and fuzzy and we were holding hands, that's why.
But it's still there until you tell somebody, give us a suggestion to take it away.
Okay.
Is it something we need to leave on the table? I mean, why not have them remove it from the rule?
I'd be happy
No
to.
one's moving forward with it.
I would be happy to open up all 5 options and look for one, but that's just me. And you know what that option would be.
I'm rather of the opinion that when you have a hive of bees that are kind of not stinging you, that you shouldn't go poke it. But it's just me.
Okay, so this will not be on the next agenda. How's that? All right.
Put it down.
Number 17 is a reminder that Chapter 157 is open for comment. I'm sure everybody's read it. Does the state need anything specific from us on it? Nope. All right. We already had number 18, the report from Air Medical and Ground. Is there any public comment? Going once? I count quickly. 2. Gone.
Did we ever
Dudley,
get
man,
that?
how'd you pass that up?
Like kids before?
Very impressive.
She's not here.
Not pending.
Summary for the GETAC meeting itself. I'll mention what we've approved for our webpage to add on there as far as the physicians and the handbook. I'll update them on some of our discussions. I'll let them know that we possibly will be bringing 2 position statements to them next meeting. One on EMS transport to freestanding ERs and urgent care centers, although I don't think we'll get that done in one meeting by any sense. We may be able to get the one on medical director responsibilities for EMS students. Any other agenda items for the next meeting? Anyone in the audience have an agenda item for the next meeting? Okay, I do have a request that our next meeting be on the Saturday of the GETAC committee meetings, since the Sunday is the, what's the Eagles? The Egos Conference, yes, I didn't say that.
Egos.
He said it first, and he's one of them, so. My cities are too small. If there is no further business, we will be adjourned 2 minutes early.
Wonderful.
Well done.
Excellent, thank you very much.
On the way down.